Good afternoon, good morning, good evening. It is good to know everybody's here. We are with Dr. Angela Fleischman today, and Angela has spoken at many of our events and on previous webinars. Angela has done amazing work in looking at familial MPNs and what's happening in that area, but also she has delved into the idea that the Mediterranean diet or a Mediterranean diet can be very useful and practical for MPN patients and for a lot of people. But we're going to talk to her today about what her findings have been with specifically MPN patients. So, welcome. I'm so glad to see you, Angela, and I'm sure it's a lot warmer there than it is here in California.
It is warmer, but we have a week of rain, which is
Oh,
quite unusual. But it's
wow.
really not that bad. But people are making a big deal out of the rain. But
Well,
yeah.
we're happy to have you with us today. So I'm going to let you, if you would, we will start to get a lot of questions. Typically, they start coming in right away. And what we'd like to ask you right away is, what have your findings been? You and I have talked about this in the past. I'm almost 100% Mediterranean. I try to eat a more of a Mediterranean diet. Of course, fall off of that frequently, but what are your findings and what do you hope for MPN patients?
Okay. So I will start out being very broad about sort of my perspective on the use of diet and other lifestyle interventions in myeloproliferative neoplasms, just so the audience knows where I'm coming from.
Right.
So with regard to diet, um, I I um, feel diet is part of the general healthy lifestyle. Um, as opposed to many times when people come to me in clinic or ask me questions, what they're seeking is a specific component of the diet that will specifically reduce platelets or change their blood counts in some manner. I just want to be clear that that's not the way that I perceive diet, um, more as a global um, uh, sort of beneficial aspects of your health. And
Absolutely.
so I think it's less important to focus on your blood counts because those are only numbers on a piece of paper, which realistically, other than hematocrit and potentially white blood cell count, we don't really have you know clinical evidence to support that one's, for example, platelet needs to be a certain number. Um, but however, we do know that in particular, JAK2 positive MPN patients do have a significant increased cardiovascular risk compared to the general population, and that is totally separate from your blood counts. So I'm really approaching myeloproliferative neoplasms with regard to diet, not necessarily as a blood cancer per se, but as a condition where people have an increased risk of cardiovascular disease or heart
Absolutely.
disease. So, from that perspective, that's where I think that diet can really be of benefit. That, getting away from thinking about your managing your blood counts and really thinking about ways that you can optimize your cardiovascular heart health because of a risk factor that you cannot do anything about, namely your myeloproliferative neoplasm. So that's the perspective that I'm coming from. Um, and so with regard to Mediterranean diet, we thought, well, obviously diet is the mainstay of sort of the first line of defense for general health, for cardiovascular risk reduction. So why aren't we really emphasizing diet in patients with myeloproliferative neoplasm? Um, so thinking about what diet would be good, um, would need a few different things. Number one would be well regarded to be healthy and heart healthy, and then number two, something that people can actually follow. Because a very strict diet does no good if you can't follow it. It just
Right.
it doesn't make any sense. So
Right.
that's why the Mediterranean diet was a very sort of reasonable diet to land on, because actually there was a very large study um, looking at the benefits of a Mediterranean diet for cardiovascular risk reduction, with regards to sort of clinical endpoints as well as biochemical measures of inflammation. So that's why we focused on the Mediterranean diet. And for first studies, one does need to start slow. You may think that, well, why can't you do everything in a single study and like demonstrate that a diet has significant impacts on a disease? But first, we needed to establish that if we provided an intervention such as dietitian counseling, can patients actually change their diet?
Hmm.
That sort of was the first step. And we did two studies um, to ask those points, and in those studies could then, as an um, additional information, then could gather things like blood counts, inflammatory proteins in the blood, cholesterol, and symptom burden. But the study was not what we say powered or statistically set up that we could actually make specific statements about the diet impacting those endpoints. So I guess bottom line, for in-person dietitian counseling, whereas one-on-one dietitian with the MPN patient, in addition to a set of weekly educational materials that we tried to make colorful and friendly and interesting to look at. MPN patients were able to change their diet to adhere to a Mediterranean diet, and there are specific scoring tools that is used in the literature to quantify how consistent a person's diet is with the Mediterranean diet. So I guess that's bottom line. We did see some trends, I would say, in reduction in inflammatory proteins, but really can't say anything more than that, because just the study was not designed to make any statements on inflammatory proteins. Also, interestingly, we did see significant improvements in people's symptom burden, which makes sense.
Hmm.
I mean, it makes sense. If you're eating better, you're going to feel better. And not unexpected, didn't really see any changes in blood counts. Um, then the next step that we did, and this was during COVID, did a fully online Mediterranean diet intervention. And amazingly, MPN, really speaking to how engaged and interactive and dedicated MPN patients are, um, almost all patients were very consistently filling out surveys online, doing Zoom visits with the dietitian. So we found that MPN patients can really do a lot of things online with diets. We did find that for certain things like extensive surveys, those are a little difficult. I I totally, I wouldn't want to fill out all those very extensive surveys in terms of 24-hour diet recalls. So for certain things, we realized that it's just not feasible to expect people to do things online. And for subsequent studies, we'll facilitate 24-hour diet recalls by just having a person call them and making it easier on the person that we can quantify what they're actually eating. Um, Moving on now, what we would like to do is honestly a little bit more of a aggressive diet. I would say aggressive diet, but with the idea that potentially a Mediterranean diet may not, maybe MPN patients, because they have an increased cardiovascular risk, maybe they need a little bit more of a heart healthy diet compared to the general population to really reap those benefits. So interestingly, in our next much larger dietary study, we're actually going to be investigating a plant-based diet. So a plant-based diet that's fully vegan, diet versus a diet that is allowing for some lean animal proteins, which will be in three phases. Number one, the first time in month blocks, where the first month block we're going to provide all of the food for the patients. Second month block, provide groceries and cooking classes. And then for the last 2 months, education only. With the hypothesis that when we are fully controlling what people are eating, a vegan diet will be, we propose that it probably will be superior to a diet that contains a little bit of meat. However, when people are in a free living circumstance and are in control of what they're actually eating, then the benefits of the vegan diet probably go away, because the person's probably going to be cheating with things that may not be healthy. So prescribing a diet that is healthy, but within the reason of what person is going to be feeling satisfied with, is going to be, in the whole scheme of things, better than a very strict vegan diet. And another aspect of the diet that we're going to focus on is also fiber. And the Mediterranean diet, because it has lots of fresh fruits and vegetables, is intrinsically high in fiber. But in our next diet study, are going to specifically focus on making sure people get a good amount of fiber, because there's many benefits of fiber in terms of the diet. But I hope that was sort of a maybe a piecemeal discussion of our diets. But the main purpose is I want to sort of move the focus in MPN away from this, the treatment of a quote blood cancer, and really focus on it as an inflammatory disorder and a cardiovascular risk disorder, and really address those issues.
I think it's great. I seriously think it's great. Having been around for a long time and hearing the different stories from patients, and I'm so glad you're doing this. I just, and it's so interesting, Angela, because so often in other disease groups, there's not a lot of discussion about diet and exercise and these other things that could really, really impact the patient's life. And so I've got several questions here. You talked about fiber, which is excellent. That's great. A lot of older people, and I'm one of them, have been told you need a certain amount of protein in your diet, because I could easily just eat fruit and vegetables and be very satisfied. But, so I was recently told, and I think it's out there, that a lot of our patients, the older patient, needs 70 to 130 grams of protein a day. And so how do that's something that I know beans, I eat fish, I eat, some of these other proteins, but, and I don't want to talk about me specifically, but for the older patient that's out there that does need more protein, or at least we're told we need more protein. How would you approach that?
So I have to say that protein is not an aspect that I'm choosing to ignore, obviously, but that is something that we haven't necessarily emphasized. I mean, in terms of, and in particular, it's very relevant for a vegan or a plant-forward diet where you're not getting that protein from meat. Um, I would say, I guess it's a personal decision, personal in terms of what you personally like. In terms of me personally, I love beans, so eat a lot of beans. I don't particularly care for tofu, but will eat it sometimes. Um, so I think if if you're focusing on a diet that is not intrinsically, rich in meats, do really have to, I would say, work hard to get that protein in, but finding protein sources that you like, um, is, is critical. Personally, I hate the taste of those protein powders. I just cannot
Oh, I can't stand
stand
those
them.
either. Yeah.
Um,
But
but
the fish part of it, because Mediterranean diet has a lot of fish. I mean, there are a lot of recipes for fish, and so that does help me, but I want it to help everyone. All right, let's go to another question here. This question came up a couple times. Does turmeric really help with inflammation in MPN patients?
So there are multiple studies showing that turmeric or curcumin is an anti-inflammatory. One issue may be, if it depends on how you're actually taking in the turmeric and are you actually absorbing it with regards to, are you actually deriving the benefits from what you're taking in? Some of the uh, supplements do include black pepper, which allow for better absorption. So I guess I would say that yes, scientific studies do show that curcumin does reduce inflammation, but simply, putting a little scoop of turmeric in your tea in the morning may not really be giving you a good actual absorption of the curcumin.
Hmm. And one of the other questions I really am glad we got this question, and that is there a blood test to check for inflammation? Um, I'll let you answer.
So that is something that is really, I don't say quite frustrating, but is an area of real need. Um, because we do have, there are markers like CRP or, ESR, which when inflammation is very high, those will be elevated. But in reality, you don't need a test to show, like if those are high, there's probably going to be real clinical evidence that there's inflammation. One thing in our studies that are really struggling with is that there are panels of inflammatory cytokines, and if look at the you know papers coming out from clinical trials or presentations from the American Society of Hematology, all of the clinical trials will show some heat map, which is like just a box with different colors about inflammatory cytokines. However, those can be a little bit deceiving because many times the levels are so low that they're going to be showing a twofold increase, but it's zero point 0.5 picograms per milliliter to 1. Is that really a significant difference? So I guess bottom line, I don't there you can there is not a definitive test that you can do that will say, oh, your inflammation is high. I think part of the reason for that is one person's sort of picture of inflammation may be different than another person's picture of inflammation. And so there is likely not one specific inflammatory protein that is going to be, quote, elevated in everybody, but maybe one person's inflammation will be manifested as, increases in certain inflammatory proteins, but not others. And then another person, um, uh, other inflammatory proteins. But I guess bottom line, there is not a standardized, panel to look at inflammation.
Um, so would you say an inflammation disorder is more of a cytokine disorder?
Yes, I think that what we can say is the cytokines that we can measure in people's blood are they're both, I guess, a biomarker of inflammation, just something that we can measure that's saying that, oh, your inflammatory cells are very active, and also can be direct contributors to, what we regard as inflammation, like heat, swelling, those sorts of things. So I think cytokines are the easiest way that we can quantify in living humans inflammation. I mean, it would be extremely difficult to take cells from a person and put them in a dish and then, you know, look at their behaviors and seeing how the immune cells are actually reacting in a dish. I mean, that's really just not a feasible approach to measure inflammation in clinical practice.
Mhm. Do you know that some of our patients are on statins, not just for high cholesterol, but this question is about do statins decrease inflammation?
So there are many benefits of potential benefits of statins, and yes, reduction in inflammation is one of the proposed benefits of statins. I mean, from my perspective, for example, if an MPN patient had high cholesterol and was, a candidate for a statin, great. You may be killing two birds with one stone. I'm just not sure outside of the context of a clinical trial, whether at this point in time it would be really, I don't say appropriate or standard of care to prescribe a statin simply for the anti-inflammatory benefits in somebody who wouldn't need it or wouldn't be an appropriate candidate for their cholesterol. But that being said, you know, with regards to management of cholesterol, because MPN is uh, patients do have an increased risk of cardiovascular risk factors, one should be aggressively reducing their LDL. So I would probably say that probably most people in this world probably are candidates for a statin.
True. What are your thoughts about the is it GLP-1, the weight loss drug? What are your thoughts about that drug and the possibility of helping MPN patients?
So that is another emerging topic, which is ripe for investigation in MPN. So again, I think um, scientific studies need to be done in MPN before prescribing GLP-1 agonists simply for MPN. But again, because if we're addressing obesity, obesity drives inflammation, obesity drives cardiovascular risk. So if an NPN patient is a candidate for these drugs for other reasons, obviously, it no data that we have would suggest that GLP-1 agonists would be bad or contraindicated in MPN. So I would say go for it if you have other indications for it. But again, I think it's a little premature to prescribe these specifically for MPN without having scientific studies to back them up, which one can anticipate that those are underway.
Yeah, yeah, I think so too. This question is, I think, appropriate. This person uses a sauna quite often, and does that help with inflammation?
That's a good question.
Yeah.
And that's something that I've always, wondered about, in particular, for example, a PV person who gets, really itchy after hot showers. I would assume that a sauna would make them feel even worse, but I don't, I don't know that to be the case. Um, I have to say, I don't have an answer to that. All I have to say is from personal perspective, um, I absolutely love hot yoga, which is not as hot as a sauna, but the way that I feel, it is just an absolutely like relaxing and just I fully believe in the benefits of I mean personally of hot yoga. So I'm assuming that maybe a sauna has the same effect.
So have you seen, and this is a great question, have you seen a decrease in other symptoms? For example, the PV patient with itching, directly related to the diet, to the Mediterranean diet?
I have to say that the small cohort of patients that we have um, had, I that did not that aspect did not strike me. So I don't think so, but I can't be sure. It was not something that came to my attention from
Right.
from our cohort of patients.
And what about red light therapy?
Oh, um, I that's a little beyond the scope of my expertise. So I really don't feel qualified to answer that question.
Okay. And so some people are asking, how do we get into your study? And unless you already have that cohort of patients.
Um, no. So, in order to do studies, you need funding, and we've now are on our third try at the NIH to
Mhm.
get funding for the study. So, hopefully, we'll get funding at some point in time. We just submitted our third application just in October, and hopefully, now that the NIH is opened back up, probably reviews will be a little bit delayed. But so bottom line is we need to get funding from the NIH in order to perform these studies. Um, and with each rendition has sort of tweaked it a little bit based on critiques, and have hopefully third time's a charm.
I hope so too. And if you need our help in any way, let us know, in terms of writing letters or so on, because we do that quite often. Do you think other diseases that maybe have not been identified until they become an MPN patient drive the creation or the development of an MPN?
So, with regard, what I think I can sort of answer there is I really do think, and we do have evidence for sort of a chronic inflammatory state does drive the selection of these mutant cells when they expand to a big enough bulk will then cause a clinical myeloproliferative neoplasm. So yes, I do think that a myeloproliferative neoplasm does not develop in a vacuum. There are, other factors that are going on in a person's body that will facilitate the expansion of those. I'll just say JAK2 because that's the most common MPN mutation, facilitate the expansion of those cells. Because we do know that many, many humans have JAK2 mutant blood cells, but in only a fraction of those people in whom there exist JAK2 mutant cells, do those cells expand and cause an MPN? So there's got to be sort of environmental factors that are going on in a person's body that allow for those cells to expand and cause an MPN.
Yeah. So interesting. And would you have you seen the white blood count decrease with a patient that is eating a Mediterranean diet and exercising? I mean, have you seen any evidence of that?
Um, I have to say, I mean, I don't I don't recall. I mean, obviously, MPN patients' white blood cells counts can sort of fluctuate going up and down. It's, I mean, it's very conceivable. You're eating better, you're exercising, your inflammation level is going down. Yes, obviously, your white count's going to go down. I mean, that would happen in any person with or without a myeloproliferative neoplasm. Chronic inflammation causes our white count to go up. So I would say that I can't in my mind think of specific um, uh, cases of that, but I mean it makes a lot of sense that it would.
Right. So some patients know that you've done familial studies. So do you mind if we shift gears a little bit?
Sure. Yep. Oh no, I
Okay.
don't mind. I don't. Let's do it. Yeah, sorry. I don't mind.
Oh, okay. So, oh, and one more question. Any connection between celiac disease and MPN?
So, not necessarily celiac, unless I'm missing publications, but there was a study looking at, or there I can recall two different studies. One where they were looking at a history of autoimmune diseases,
Uh-huh.
which would include both, like psoriasis and lupus, as well as inflammatory bowel disease, like Crohn's disease or ulcerative colitis. And though a history of autoimmune disease does increase one's risk of myeloproliferative neoplasm, another study actually looked at a inflammatory bowel disease clinic, which would include not only celiac disease, but all inflammatory bowel disease. And they screened those people for JAK2. They took people whose platelet count was a little bit high, and it looked like about 25% of those people had detectable JAK2. So I can say that based on, you know, um, literature, like to my knowledge, I don't think, or I mean, I could be missing a paper where they specifically took a cohort of people with celiac disease and then checked for JAK2. But there is circumstantial evidence to suggest that yes, I would say that any disruption of the gut
Hmm.
is very feasible to increase risk of a myeloproliferative neoplasms. In other This is getting a little bit away from myeloproliferative neoplasms, but in a related sort of, I don't say disorder, it's more of a phenomenon called clonal hematopoiesis, where people
Hmm.
can have mutant cells in their blood, but have no blood count abnormalities. This is in mouse models, but in multiple mouse models, when they experimentally disrupt the gut with chemicals, that they see those cells surge. So in mouse models for other mutations, it's clear that if you disrupt the gut barrier, you're going to get these mutant cells surging in the blood.
Interesting. And so that kind of goes along the line of the women that I know that started out with breast cancer and had breast cancer treatment, and after their breast cancer treatment, developed an MPN. Is that kind of the same? I mean, it's not the same, but can you expound on that a little bit?
So yes, I guess this is another sort of emerging. I guess we probably need to sort of rethink the way we think about how blood cancers emerge. So maybe the common thought would be, well, if you get chemo, that chemo is going to cause mutations, and those cells are going to then expand. But what's interesting in studies where they had longitudinal samples from people who got chemo and then subsequently developed blood cancers, and they had blood samples even before they got the chemo, that those cells existed before the chemo. But what happened is the chemo selected for them, so created an environment that allowed those cells to gain a selective advantage over the normal cells. Um,
Okay.
and there are particular mutations, um, not necessarily JAK2, but other particular mutations that are very unique to emerging after certain types of chemotherapy because they're resistant to that type of chemotherapy. So they're pre-existent, but they were just selected for during chemotherapy.
Mhm.
And that may be the case with myeloproliferative neoplasms as well. Um, because we do know in most people, I mean, obviously you're not going to know this for everybody, but in studies, one can track back the presence of the JAK2 cells for 20 to 30 years prior to their diagnosis, in some cases, even at birth. So it's not that these mutant cells just appeared out of nowhere. They had
Right.
been hanging around for decades.
Wow. So one last question about diet, and then we'll ask you a few questions about your familial study. And I would say, high sugar content in your blood is not good anytime. But but the question is a high sugar in the blood, but also in your diet, you know, bad for MPN patients or, can cause problems for MPN patients.
I would say if you're asking the question because, say, for example, the concept that sugar fuels cancer cells. Um, you know, I I don't know how much discrete data there is specifically for JAK2 mutant cells with from that perspective. However, maybe from a more sort of global perspective, that I think that high sugar is not good for your cardiovascular risk. So I think probably less so. I mean, I just don't we just don't have discrete data about glucose content and how JAK2, how eating sugar may impact your JAK2 mutant cells, but it's clear that, eating sugar may cause, you know, you know, insulin resist. So it's just not good for your cardiovascular
Right.
health.
Right. So let's jump over to the familial studies you've done. And over the years, I have seen so many people one time at one of our events in California. I don't know if you were there or not, but a gentleman stood up to ask a question, and there were five of his family members sitting in the row, and they all had an MPN. And some had ET, some had PB and but five family members all had a blood cancer. What have your findings brought to the surface? Like, what highlights can you give us?
So what I can say, I think we're approaching this from a few different angles. Um, I can say that what study is sort of most advanced is us trying to identify what specific circumstances are highly selective for JAK2 mutant cells. So our basic hypothesis, so with families, um, what's really interesting is that, people do not you don't pass down the JAK2. Well, we'll just, we'll focus on JAK2 but when I say JAK2, I'm really meaning JAK2, calreticulin, and MIPL, but just for simplicity, I'll just
Mhm.
I'll just say the word JAK2. Um, that 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 the mutation isn't passed down, but the tendency to have cells with a JAK2 mutation or a calreticulin mutation grow inside your body is passed down. So what our hypothesis is there's something very specific in the sort of the the environment of MPN families that really likes to have these JAK2 mutant cells grow out, which may not be present in the general population.
Mhm.
Um, and also leveraging the fact that autoimmune diseases also run in these families made us think that there might be a very specific, I don't want to say defect, but variation in these families' immune system that may be overactive in a very specific manner. Um, and we interestingly found that in MPN patients, and interestingly, their unaffected family members, um, they have a lot of difficulty turning off inflammatory signals. So what's interesting, we found when you give inflammatory proteins to or like bacterial components to immune cells, a normal human's response should be they need to respond to that. And so early on, they produce a lot of these inflammatory cytokines, but then they know how to turn it off because you mount the response to the bacteria, you kill it, and then you calm down. Um, but with MPN patients, interestingly, they're sort of slow starters. So they're sort of a little slower to start the inflammatory response. But once they start it, they have a lot of difficulty turning it off. Um, and we found that that was mediated by their inability or sort of they're less able to respond to this anti-inflammatory protein called IL-10, um, which can explain why these people and defects in IL-10 signaling in mice and in humans can lead to inflammatory bowel disease. So it makes sense that if sort of I don't want to say defects, but just a little bit, they're just not as able to respond to IL-10 to dampen the immune response as sort of the general population. This could explain why they have more of a tendency to have autoimmune diseases, as well as have chronic inflammation. And then in mouse models, we experimentally blocked IL-10 and found that the JAK2 mutant cells grow very well in mice when we block IL-10 signaling, which is interesting and supports the idea that defective IL-10 signaling may be an underlying feature of MPN families that allows JAK2 mutant cells to grow very well. So we're investigating that a little bit more. specifically in MPN families, as well as more specifically in cell lines, as well as mouse models. Another approach that we're taking, which admittedly is has been a little bit difficult technically to try to identify what's the best way to really identify these things, is wanted to we have a large cohort of MPN patients and their family members, their blood, which we have stored, with the question of maybe MPN family members who are unaffected may not have JAK2 mutations, but may have emergence of cells with other mutations that maybe play the same role as JAK2, but don't have any bad consequences. Um, and I do have to say that we're technically coming up with a lot of roadblocks in terms of how to really execute those the analysis. I just have to be honest that
Mm-hmm.
sequencing, trying to find a balance between um, being very comprehensive and then versus being very targeted is sort of a fine balance, and we really haven't found that yet. So I would say we're having technical difficulties with um, uh, trying to identify the right approach
Mm-hmm.
to identify mutations in people's blood.
I have three more questions here, and that are varied. One is, and it's just so interesting. This patient said that she was prior told that her MPN was a disorder, which it used to be called MPN disorders. And then I believe in 2007, maybe the World Health Organization redesignated MPNs as blood cancers. What are your thoughts? I mean, I still refer to them as blood cancers. And would you say they still are blood cancers?
So I would say technically they are. Um, and I mean, this is my perspective in terms of, and can tell you why they were moved from a disorder to a neoplasm, is that our previous definition of a quote cancer or neoplasm was you've got a mutation and those cells are expanding. So in 2005, the JAK2 mutation was identified. And so after that, with MPN patients having JAK2, calreticulin was identified in 2012, that they fit the definition of a quote a cancer. However, subsequently, we now know that about 20% of people over the age of 60, if you test their blood, they're going to have mutations in their blood. And actually,
Mhm.
JAK2 is the fifth most common clonal hematopoiesis mutation. So now, if we have a definition of having mutant cells in your blood being a blood cancer, then, and it's almost everybody over the age of 90 will fit that bill. It's almost inevitable for you to have mutations in your blood by age 80 or 90, then almost everybody is going to have a cancer. But what differs from, I would say, clonal hematopoiesis is you don't have any clinical abnormalities. You have blood count, your blood counts are normal. So I would say that yes, technically, myeloproliferative neoplasms are, quote, a blood cancer, but do have to acknowledge that a large proportion of healthy aged humans also do have mutant cells in their blood, and many of them do have JAK2 mutant cells in the blood. But what distinguishes a myeloproliferative neoplasm from simply clonal hematopoiesis of indeterminate potential is the presence of blood count abnormalities.
Mm-hmm. Excellent, excellent answer. Okay, this person asks if an MPN can um, cause problems with erection dysfunction, and I'm guessing yes, but you can answer that.
I mean, that's a I yes, I guess from many different, from many different aspects. If a person's platelets are very high or their hemoglobin is very high, may be interfering with blood flow. Um, um, I know there have been studies in terms of not necessarily, erection per se, but more just um, the
Sexual
whole
function and yeah,
sexual function.
yeah, yeah.
Um, but I mean, I don't have any specific data on that, but theoretically, yes, it can
There
affect
were
that.
studies, and I think the studies were more about how the disease has impacted the more intimate relationship, physical intimacy, and but I don't think it ever specifically said EDS. I don't remember that, but I'm sure it can. And then finally, we are this group of MPN patients keeps growing and growing and growing, and probably on this webinar and subsequent webinars and past webinars, we end this and we look at how many new patients have come to these webinars. And Angela, it's usually 60 to 80. And so and then those watching, the video afterwards, the YouTube video afterwards, it just grows from there. So one of the questions was, hey, my wife and I both have an MPN. And I talk to people all the time, as I'm sure all of us do. And 9 times out of 10, a person will say, oh, my uncle has it, or my brother has it, or, my brother now has CLL. And so, I think because of blood tests, but what is your take on that?
Yeah, I think that it is just revealing that, a lot of times people say, "Oh, MPN is so rare," but I'm like, "Well, I
I
don't
don't
think
think
so.
so. Me neither.
It's not really that
Absolutely
rare."
not. Yeah.
Uh, yeah, funny. I was talking to a friend who, he knows what I do, but doesn't really. He was talking about his friend who he runs with, and he says, "Oh, well, he has polycythemia." I said, "Oh, yeah, that's exactly what I study." So, it's you know, you just, you don't really
Oops, I
be
lost
talking
you.
about it,
Yeah,
in your day-to-day conversation. Oh, you don't really think about talking about MPN in your day-to-day conversation, but you might be talking to also somebody who has an MPN. But it just is, it's probably a lot more common than we
I think
realize.
so. And Dr. Messa and I always say we don't think it's a rare disease much anymore. But my neighbor came over the first time she moved here. I made her a little breakfast and she walked in the door and I said, "What do you do?" And she was a professor down the street and she said, "I have this rare blood cancer." I said, "Oh, what is it?" And it was polycythemia vera. And so, it just seems like, and more people are being diagnosed because they're having their blood checked. Even that's why our pediatric and young adult group grew because more pediatricians, when they get a new patient, are doing blood work, complete blood counts, and they're finding an MPN in these younger patients. So I'm glad for that, but I do think I don't agree with that being a rare disease either.
Yeah,
So
and
go
we could
ahead.
have a whole conversation about, and do not want to bring it up
Yeah,
at the end of this, but is it better off knowing or not knowing? Because in
absolutely.
particular, in some younger patients, it in whom we're not really intervening. In, for example, like a younger calreticulin mutated ET patient, which we're not really going to do anything about anyway. That is, it is having this diagnosis not a positive, but it only causing them additional stress. I fully acknowledge that it's probably important to know where your risks
Yes.
are,
Yes.
but do need to also acknowledge the sort of anxiety burden that having this diagnosis does also bring.
And especially with young people that we know and talk to regularly, their whole lives are ahead of them. And, they're dealing with this particular thing right now. And so we try to help them through that. But before you leave us, I mean, you've given us some great food for thought, if I don't mind saying that. Anyway, and so, what other wisdom would you impart to MPM patients before we hear from a few of our industry partners? And I like to bring them on because there's so much going on with new drug development and so on. And so what would you like to impart before you leave us?
I mean, I would say, and this is sort of funny to talk about right before we're talking about new drugs, um, but I think that you are in control, and the treatment or the management of your MPN is not simply medications and or potentially phlebotomies, but really there are many other things that you can do to manage your lifestyle to admittedly not make your MPN go away. I don't in any way, propose that
Right.
that's the case, but can help to manage your symptoms as well as manage some of the sort of negative consequences of the myeloproliferative neoplasm. So I fully believe that, things that you can do may actually be more beneficial in the long run, or I say more impactful in the long run than simply relying on pharmaceuticals. But
Absolutely.
but but pharmaceuticals clearly have
Yes,
play
I
play an
know what you're
important role.
saying. Yeah,
Yeah.
we know what you're saying, and you're absolutely right. You mentioned, we talked about diet, we talked about, you said you do hot yoga. We have Natalie who works for us, who is a yoga instructor, and we want to bring that back and start doing because she had a small following, but I think it's so beneficial to our patients, but also exercise and just for all of us, but specifically for MPM patients to pay closer attention to their daily lives and what they're doing and what they need. And some, as see therapists and are in groups and anything that will help them, I think is great. But thank you so very much. I know you're really busy and we so appreciate your time.
Well, thank you. I love nothing more than talking about myeloproliferative neoplasms. So this is fun.
That's funny. Thanks, Angela. We'll be
Yeah.
in touch and we'll
Okay.
move on now to
Okay.
our industry partners. We're going to hear from Bart Dien, I think. I'm not sure if I pronounced that correctly, Bart, from Pharmacentia, one of our long-term partners.
Thank you, Anne. Yeah, but DMA is
Oh, okay.
correct.
I had
Yeah.
that spelled wrong. I'm sorry.
Yeah. No, no, that's very close. Thank you. And so I am a pharmacist and medical science liaison working for Pharma and really wanted to thank MPN Advocacy and Education group for inviting us to be part of this very meaningful event. It's truly an honor for us to be here and to share what we are doing really like, as everybody is gearing towards helping to improve the life of people living with MPNs. So global research, as you know, is continue to move at a very fast pace. And at Pharma Essentia, we have recently completed two trial using our drug Besremi in the ET space, and this has recently been part of a FDA submission to consider Besremi for patients living with ET. On top of that, we have a phase 3 trial in the pre-PMF or early stages of myelofibrosis. So really like doing our small part to help really, advance the science. And in addition to the very excellent information you can get at the MPN advocacy like website and the resources that they provide, you can really find information about Pharma Essentia and Best Remy and the research we do at pharmaessentia.com. So again, I'm really, really blessed and feel excited to be part of this, group and honored to be in here sharing this stage and really thank you for your willingness to share your experiences because as you kind of voice yourself, we can use this information to advance the science. So thank you very much.
Yes, that was excellent, Bart. And we're real excited about the ET, Best Remy being possibly available for ET patients soon. So that will be great. Thank you very much, Bart.
Thank you, Anne. Thank you.
And we'll move on to Liz Schaefer from Merck. Are you with us, Liz? All right. Kimberly, are you here? Kimberly Price from Cartos.
I am.
Oh, there you are, Liz. I'm sorry.
Sorry,
I'm
I was
sorry. It
having
just took a
trouble
minute. Sorry, Kimberly.
getting off.
Liz came back.
Sorry, I was having trouble getting off of mute. I apologize.
Okay.
Hi, my name is Liz Schaefer. Thank you for having me here today. I'm a clinical research director at Merck. I'm working on hematology trials, and today I'm pleased to share information on two ongoing clinical trials for essential thrombocythemia, which, as you likely are aware, is a chronic blood disorder where the blood produces too many platelets, increasing the risk of blood clots, bleeding, and fatigue. The trials that we have are evaluating an investigational medicine called bomedemstat. MK3543 is our Merck number. So our first study is MK3543006 with an NCT number of 060-79879. It's a phase 3 trial for patients with ET who have had an inadequate response or who are intolerant to hydroxyurea. And that's a commonly used cytoreductive therapy. Participants are randomly assigned to receive either the investigational medication, bomedemstat, or the physician's choice of best available therapy. The study is actively recruiting participants globally and aims to enroll approximately 340 patients. We have 17 sites participating in this study across the United States. The second study is 3543007, which is NCT number 064-56346. It's a phase 3 trial for patients also with ET. These patients have not been previously treated with cytoreductive therapy. It's a double-blind, randomized study comparing the investigational medicine, which is bomedemstat, to hydroxyurea, which again is a commonly used cytoreductive therapy. The study is also actively recruiting patients globally and aims to recruit approximately 330 participants. And in this study, we also have 17 sites participating across the United States. So for a full list of participating sites for each of these trials, you could search on on www.clinicaltrials.gov or go on merckclinicaltrials.com and search for essential thrombocythemia. So
Thank you. That's great.
thank you, Anne.
Good to know. Thank you very much. And we'll see you soon at ASH, I think. And now we'll move on to Cartos and Kimberly Price. Hi, Kimberly.
Hi, Anne. Thank you so much for the opportunity for us to share this update on the POESIS study today and for all the work that you do with the investigators as well as the patients and caregivers. So I work in medical affairs at Cartos Therapeutics, a company developing a new medicine called navtemadlin. Navtemadlin belongs to a class of drugs called MDM2 inhibitors. So I'm going to share how that works and then our study design. So our bodies have a natural tumor suppressing pathway controlled by a protein called P53. In healthy cells, P53 detects problems and can stop those abnormal cells from growing. In myelofibrosis, this pathway is often turned off because of another protein called MDM2, which blocks P53. When that happens, the abnormal cells multiply unchecked. So the idea is that navtemadlin is designed to block MDM2, which allows P53 to turn back on. Now, POESIS is a phase 3 double-blind registrational trial enrolling patients with myelofibrosis, either primary or secondary, who have a suboptimal response following treatment to the JAK inhibitor ruxolitinib, also called Jakafi. A key point of the POESIS study is that patients cannot already be on Jakafi when they join the study. The reason is we need to measure how patients are doing before starting Jakafi. So some recruitments or requirements for participation include the diagnosis. Other conditions also must be met, and you can reach out to your participating center for more details. You can also go to the poesiswebsite.com. I have the spelling here. It's POIESISS trial.com or clinicaltrials.com as well. We are enrolling patients in over 250 centers globally and over 70 centers in the United States. Thank you so much for
Fantastic.
allowing me to share.
Yeah, I mean, I think it's fantastic. If I were a patient right now, I'd be ecstatic because there's always something happening. And some of these drugs I've watched from inception to now, and it's just been incredible. Thank you so much, Kimberly. I'll see you at ASH.
Thank you. You
We'll
too.
talk soon. Okay, and so now we're going to hear from DISC and Marcella de Sousa Santos. Hello,
Thank you.
Marcella.
Hi everybody. Thank you and for the opportunity to talk about our trial. Yes, my name is Marcela de Souza Santos, and I am a clinical scientist at Disc Medicine. And on behalf of Disc, I would like to introduce you to the Rally MF clinical trial today. This is a phase 2 trial that is open to eligible patients with primary or secondary myelofibrosis and anemia with hemoglobin less than 10 grams per deciliter, or patients who are requiring transfusions. Patients may be enrolled regardless of or whether they are or not on MF-directed therapies such as JAK inhibitors. And our study drug is DISC-0974. It's an investigational monoclonal antibody that DISC is studying for the potential to reduce hepcidin, which is a protein that is abnormally high in patients with inflammatory conditions such as myelofibrosis. The goal of our study is to understand if treatment with DISC-0974 can improve anemia and reduce blood transfusions. The study will also be collecting information regarding the safety of DISC-0974 and any side effects or risks, and to better understand how improvement in anemia may also improve the way patients in MF feel and function. The drug is administered as a subcutaneous injection monthly for 6 doses, and patients who show benefit have the option to continue the investigational drug for a longer period of time. The trial is now enrolling at many sites across the country, so if you are interested, please refer to our website or to clinicaltrials.gov for additional information. Thank you.
Thank
I
you very
appreciate
much.
this
It's
opportunity.
just so there's just so much going on. It's incredible. Thank you very much. And now Joe Loers from Silence Therapeutics. Joe, are you with me?
Yes, I am, man. And here comes my video.
Oh, hi Joe.
Hey, how you doing?
Good.
Silence Therapeutics is a biotechnology company that was formed in 2005 and focuses on the discovery and development of novel molecules incorporating short interfering ribonucleic acids to inhibit the expression and specific target genes in hematology, cardiovascular, and rare diseases. Silence is based in London, England, with a U.S. office in Hoboken, New Jersey, and research labs in Berlin, Germany. There are over 120 scientists and research staff at Silence, and we are proud to be a global and diverse company. So why are we called Silence Therapeutics? RNA interference involves the use of short interfering RNAs. These siRNAs silences various diseases, and they do it by using your own body's natural mechanism. Our long-acting divesiran compound is an investigational siRNA medication for polycythemia vera patients that is designed to reduce the production of TMPRSS6 in the liver, resulting in an increased expression of your own natural hepcidin. Hepcidin is the key regulator of iron homeostasis. By temporarily blocking or silencing this specific gene message, our technology aims to lower and maintain your hematocrit below 45%, reduce or eliminate phlebotomies, reduce your PV symptoms such as fatigue, brain fog, itchy skin, lowering the risk of blood clots and strokes, and ferritin levels or iron levels may return to normal levels. Silence Therapeutics is excited to announce that we have full enrollment of our Sanrico phase 2 clinical study of our divesiran treatment.
Lost you. Okay, so Joe is gone.
Sub-Q dose.
Oh, there you go. Joe, you were gone for quite a while, so do you want to wrap up?
Oh, I'm sorry about that. Yeah, I'll wrap up. So again, our Sanrico phase 2 study is no longer seeking PV patients. We are fully enrolled, And once our top line data from the phase 2 San Rico study is presented, development of our phase 3 trial will begin. We hope to open many U.S. sites for phase 3 and hope to be using the every 12-week sub-Q regimen. To learn more about Diverseran and stay up to date on the phase 3 status, please go to www.silence-therapeutics.com. And again, thank you, Anne, for this wonderful program and your wonderful work with MPN patients, MPN specialists, and terrific programs just like this one.
Thank you, Joe, very much. And we'll probably see you at ASH as well and many others. And so in parting, I would like to let you know that Dr. Bose will be doing a webinar on December 12th. He'll do an ASH update and answer any of your questions, but we will see you again in December. I don't think we have any more in November this month, but we will see you right after ASH in December. And thank you so much for joining us, and we're here if you need us.